Hello and welcome to another episode of Everything Digital Health. I'm your host Marcus Bohr, and today I'm joined by Denise Downs, who is a SNOMED CT specialist, a terminologist, and somebody who worked for NHS Digital for a long time, someone I worked with when I was involved in GPIT policy. So Denise, do you want to tell us a little bit about how your role first of all, and then how you got there?
Yeah, so I was taken on to try and increase the awareness of SNOMED. So this was in 2009. So it was just at the very beginning of rolling the EPR systems out into hospitals. We still very much were on the read codes in GP practices.
Yeah.
And at that time, it was under the umbrella of Connecting for Health. So I think at the time they wanted a role that really didn't exist anywhere at all. And I sort of fell into that role. So my husband is Ken Lunn, and he was Director of Data Standards and Products at the time. And I was Director of Research and Knowledge Transfer at the University of Huddersfield.
Wow.
So, and one of the schools that I did a lot of work with was the School of Nursing. So nursing was quite active in terms of research, but of course we trained all nurses and put them out on placement into local hospitals. So we started, Ken knew some of the work that we were doing, and we actually, through the nursing school, did little bits of projects so that DSP could take advantage of some of the things that we'd done in nursing. And he sort of came home one day and said, I'm putting a new job description together. I need somebody who's going to liaise with the Royal Colleges. We need to get SNOMED in the curriculum. I need to raise the awareness. We need to increase our training materials. But that role doesn't exist anywhere, to my knowledge. How do we put the skill sets together to attract the right sort of person? So we kept going backwards and forwards with the job description. And I'd been in my role at the university for over 5 years. So, you know, when you've been in a role for 5 years and you're not ready for retirement, I was the one who was looking, where am I going to go next? And there was no way I was going to get any further in the university. So he came home one day and I went, actually, I quite fancy doing that job, much to his alarm, because the job was sort of not reporting to him, but reporting to one of the managers that reported to him. And he said, I can't have you in my, it's going to make things really difficult. But so it was, the guy was called Keith Naylor, who did a lot to do with messaging.
I know the name.
Yeah, and the implementation team for SNOMED came under Keith. So we sort of had a discussion that if Keith, when we put the proposition to him of me taking the job on, if Keith hesitated or gave any inclination about, I'm not sure I can make this work, then I just wouldn't apply. And actually Keith responded completely the opposite of, please apply.
Cool.
So I applied for the job.
And the rest is history kind of thing. Then you. So I will just take a second to talk about terminologies and just say what it is, the overarching thing we're talking about. And it's things like coding systems, isn't it? It's like read codes, and before it Oxmis codes, and then we had SNOMED CT, CTV3. And we are going to do a short series of this channel where we will talk in more technical detail and a little bit more like clinical detail and sort of a more of an introduction to terminologies. So some of the stuff that we'll talk about today will be explained in future episodes. But Denise, from your point of view, what was your background? How did you get from where? How did you end up doing that? Because everybody in digital health has got a kind of unusual story, which is part of the reason why these chats are so fun.
Yeah.
What was your background,
Yeah, and when I took the job, I didn't actually know what I knew a little bit about what SNOMED was, but I do not have a terminology or a clinical background. Um, so I started off actually as a maths teacher. So my passion when I was at school was maths, just to such an extent that people who didn't teach me knew I was going to university to do maths. I was, such a
Wow.
it was the only subject that I ever contemplated. But I actually picked a university that had an environment that I wanted to go in. So I partly picked my university rather than just going for somewhere that excelled in maths. And they required you to do 3 subjects in your first year before you picked your major subject. And at the time, computing was just coming in. So basically, I picked computing as one of my other subjects. We used punch cards,
Wow.
paper tape.
When was this?
A mainframe. So I graduated in 1976.
Okay, right. So punch card era.
Yeah, so quite a while ago. Yeah, so I used to carry big boxes of punch cards around with my computer program on. But things were changing really rapidly. So when I graduated, as I say, became a maths teacher. And within the first 2 years of me being a maths teacher, we started teaching an appreciation of computing in school, the secondary school that I was in. And that, because we didn't have any facilities, it used to be done with the local technical college. It was timeshare. So basically you had terminals that logged into a big mainframe that sat in a building, and we paid for our computer usage time. And I used to have to go with the kids to the technical college. And of course, excuse me, when they found out I had a degree in computing, it was actually, we're struggling to find people who know something about computing. So I started teaching night class. We got a mini computer, which the only way to start it was to put a program in with flicking switches you put the program in literally using noughts and ones.
Wow.
So I used to
old
have
school.
A script where what we call the bootstrap program was actually physically put in by hand. You put it into the memory, and then in effect you kick-started it, and then it could pick all the devices up and it ran. So if it ever crashed, which it sometimes did, it was a bit of a nightmare. You had to
put that program back in. Wow.
Again, yeah. So I worked across the technical colleges, and microcomputers started to come out. So I went to, I taught at, funnily enough, all the technical colleges in the area. I just kept moving for promotion, and ended up at Huddersfield Technical College at the time when BBC Micros came out. So we actually implemented a network of BBC microcomputers, and we had our own mini computer. We used to have to do all the backups and all the looking after the computer ourselves.
That is so cool. I remember the BBC B. I had an Acorn Electron at home. That was our first computer. And BBCs were at school. And then not long after that, the BBC Master came out, which had 128K. It was amazing. And floppy disks and things. I remember having my mind blown the first time I saw a mouse attached to one of these. And I was like, they've got a mouse. This was at Leeds Grammar School when I went to visit. We couldn't afford to send me to Leeds Grammar School, so I went to Selby High instead. They didn't have a mouse. Not then, anyway.
Well, a bit later on, I did a secondment in a company, and I used to teach the sales reps, and he tried to do the mouse up in the air like this. I was at the stage of teaching people how to use a mouse and not to put their cup of coffee on a floppy disk, because it actually wasn't going to do it a right lot of good. So,
it's like that scene in Star Trek, The Undiscovered Country, I think it is, where Scotty speaks into the mouse because he's from the future and he has no idea that you would have to manually control a computer.
Yeah. So my teaching days were all very much when all those things were coming out, and we were teaching people how to use a mouse as well
Yeah.
as how to put a floppy disk in, and how to look after it. So and then I ended up at Huddersfield University because the government put in the program that actually put computers into schools.
Mm-hmm.
So there was a national program. There were a number of themes to it. So there was computer science, there was business studies, and basically we were trying to get computers out into schools. And the Huddersfield University had a contract to be to provide one of the national leads for one of the projects. And although I was at the technical college, I asked if I would do a secondment, and I worked alongside another lady, and basically we were the national coordinators for putting computers into business studies areas.
Wow.
But I was also one of the regional leads for computer science. So
Lots
so
of
pretty
computing and
exciting.
maths background. Yeah, very cool.
Yeah, yeah, and it was an amazing time because you were trying to come up with ways all the time to make it applicable in the curriculum. I remember going out into primary school and actually teaching alongside the teacher so that the kids could use computers, and you had one in the corner. So what would often happen is I'd set it all up and work with the child and just help the teachers to get confidence in using those things. So it was pretty good.
Yeah.
But as a result of that, Huddersfield University asked me to apply for a job there. So I actually ended up at Huddersfield University in the School of Computing,
Mm-hmm.
and started teaching things like programming, so COBOL. We did use C. So those types of so I basically
Yeah.
moved into a very much a software engineering type role. But
Cool.
because I'd got that mentality of doing secondments, I actually did work on I did do quite a number of secondments. I think some of it was computing had changed so fast in that 5 or 6 years from graduating to ending up at the university that I always felt like it was a bit of catch up. So I actually did a master's in software design. And when the opportunity came up to go work in, so there's a company called Herxt that is a chemical manufacturer company.
Oh yeah.
And CRMs were, so customer relationship management systems, which I would say there's a lot of similarities between customer relationship management and electronic patient record systems. So they were just looking at putting in a customer relationship management system. I call it a CRM for short. And actually they asked me, so I used to run the placement unit. So we used to put students out in companies for their 12-month, their sort of industrial year, which was compulsory on all our degrees. So I used to visit Microsoft, visit Ford Motor Company, a lot of the companies that were doing quite innovative things with IT. So, and Herxt was one of the companies that I visited. And we just got talking and he went, will you come and work with us for, I've got this project that I need somebody to lead. Will
Wow.
you just come and put the CRM in across, well, at the time it was across Europe. So
Mm-hmm.
my manager there was the regional manager for the whole of Europe.
So would you say things are moving faster then or faster now? Because it feels like the pace of change is incredible at the moment, particularly in the past year or few months.
Yeah, and I guess the challenge is you look back, don't you? But when you consider that our only method of data input when I graduated was punch cards,
Yeah.
and in less than 10 years, I was working with sales reps who had a laptop and a
Wow.
mobile phone connected to their laptop. And so what we implemented on the CRM was they would go to a site, to a customer, and what would normally happen is they would sit and have a discussion with the customer, and they would say, well, we're interested in this product that you've got. Can you send me a sample? Can you send me the product specification sheet? And, call me back in a month when we've had a chance to look at that and see how it works. And they used to sit and they used to write it all down on their notepad, and then they used to come back into the office, and we had just 3 secretaries who supported all our sales reps, and they would type up the report. They would then speak to the lab to send off a sample. They would post out the product specification sheet, and then they would give the printed report back to the sales rep, who then had to manage, when did the follow up with customers, etc. And basically we put the whole of that onto computer.
Wow.
So my more confident sales reps at the beginning would sit with the customer, move their screen to the side so that the customer could see the screen in the same way that they could. Because what we did was put lots of little buttons on the screen. And if the customer said, can you send me this sample? They would click on a button. It would bring up a form. They could quickly, because it had a pick list, they could quickly find the sample and say, yes, this is the one that you want. This is that. Right, we'll get it out to you immediately. And then when they'd finished the conversation with the customer, they would plug in the mobile phone and say, okay, right, I'll send all that off to the office now. So in terms of confidence to the customer, wow, I don't even need to wait for you to go back to the office.
It's amazing. We still don't have really that sort of functionality in GP systems now. Like when I go on a home visit, that system is not with me. I can't take a mobile version of the complete clinical system to the bedside in somebody's house, and I can't prescribe things from where I'm at the house. I have to make notes, come back to the office, and do it all back at the ranch, kind of thing.
Yeah, and I think that was one of my big learning curves. So these things that we did in manufacturing, none of it was personal data. Mm-hmm. So the fact that, okay, it's company confidential, but the fact that my sales rep had a laptop with every single one of our customers' names, their addresses, the contacts of, who was,
I see,
who was the person in the lab, who was the salesperson, etc. I guess we didn't. To us, the business benefits were greater. We didn't,
and it's a different era as well in terms of legislation around data protection and personal data. But you had a laptop with all that data on, and you were it was on the back of a car, and unencrypted, I presume, at that era as well.
Actually, no, it was encrypted because we did actually use an IBM product,
right?
And it actually was encrypted. So
cool.
But yeah.
But yes, now that the stakes are higher, aren't they, with medical information, with patient information?
And I think the other thing with Herx, the business benefits. So in terms of our responsiveness, when all that had gone, so when the lab had sent the sample, the sales rep would get an alert, and it'd have a timestamp on it. So the sales rep on a Monday morning could go into the system, and it'd say, it would organise things that this sample was sent last week, this one was 2 weeks ago, this one was 3 weeks ago. So the sales rep could decide who they were going to chase up.
Yeah.
So I think our business benefits outweighed the risk that we felt commercially in terms of somebody having a laptop that might get stolen.
Yeah, definitely. So you told us how you got involved in health tech. So let's jump to that bit, which is, so you got hired essentially during Connecting for Health, and the project was to bring SNOMED CT in as a coding system. So, like, let's talk a bit about why that would be a good idea in the first place. What was being used at the time?
Yeah, so I think it's maybe worthwhile saying when I came in, having done everything I'd done, so I'd done the CRM for Herxt, we'd done something similar to management placements. I'd actually worked on a project with with care homes and the inspectorate that looked after care homes. So the work that I'd done around keeping these records that have got lots of text and lots of contextual information, and for me, an electronic patient record was very similar. And the fact that you'd got dictionaries and keywords at the back of it, they just didn't work without it. So I think I came in a bit naive that, well, I understand what I'm here to do. It's a no-brainer that you need a dictionary at the back of these systems because you're not going to get any benefits in the way that we had seen. It's just a case of making people aware and helping along that road. And
so versions of that dictionary were already kind of in use in primary care, weren't they? And I think in previous episodes we talked about how the original sort of Oxmis codes, and then they developed into read codes, and then there were several versions of read codes. So round about when you got involved, some of these systems would have been using CTV3, so read version 3, which is kind of an expanded dictionary, and these are a code, like an alphanumeric code, that means like a diagnosis or something about the patient, like their occupation, or some administration codes as well. And as time went on, these collections of codes got bigger and got bigger until there was an attempt to sort of make a final attempt at the clinical coding system, which is what is now SNOMED CT. So CTV3 merges with SNOMED RT, I believe.
Yes. Yeah.
And that combined to become SNOMED clinical terms, or SNOMED CT, the sort of final end boss of terminology as you would see it then.
Yeah, and I think coming at it from the terminology point of view, the proposition of going to SNOMED was from a coding scheme point of view was such an obvious thing. So we'd had an incident with the read codes where years and years ago, some conditions were classed as mental health disorders.
Yes. Yeah, I heard about this, including conditions that are actually just, human variation, lifestyle choices and things were actually put under the category of mental health, either because of the prevailing viewpoint back in the 60s, 70s, 80s, or because of lack of space in some other part of the ontology, because that was the other thing with some of the earlier systems, wasn't it? They had stuff in the wrong place sometimes because there was no more space in that part of the classification, so it's kind of stuffed into another bit, even though it was misclassified there.
And those were the dilemmas that we had. So when you have a read code, a system like the read codes, where the different characters meant something, so flipping back to my degree, that's absolutely how we designed coding schemes. I did a whole module on coding schemes and how that knowledge you embedded in, C meant this, C in the first character meant this, 3 in the third character meant this.
Yeah.
A lot of effort was put into how you design those coding schemes, because memory was, at a premium. We didn't have lots of memory. Processing power was nowhere near. So actually being able to quickly find everything that begins with the letter C, that is absolutely in the 70s and the 60s how you designed coding schemes for the computers of that day.
Yes, absolutely. To try and reduce. So if you were reducing an entire sentence about the patient that said, left left pulmonary artery embolism or something like that could be converted into a short code, and that code goes in the record. Now you've only used up 4 bytes or 5 bytes. So that was the aim of it. And as you say, sorting and filtering when their meaning is in the code makes it way more efficient if you've got limited memory, limited storage, limited processing power, and that sort of thing.
Yeah. Yeah. And so they were absolutely the right thing of their day. But as the read codes expanded, as you say, we had the issue where things were miscategorized. We actually had some codes that we got challenged with that just needed deleting. And actually, we didn't have a mechanism of deleting codes out of read. You know, there was no way to say, okay, that might be how we looked at things 5 years ago, but that clinically is absolutely not correct. And we just need to get rid of that code. As you say, we had things that should have been a child, so it should have been a type of. So, like you say, type 2 diabetes should have, and it was, because it's obviously was there a long while ago, but we had type 2 diabetes is a type of diabetes. We had other ones that we'd put more and more data in. We just didn't have the slot. Something else was already in that slot. So basically the read codes were brilliant of their day, but as we put more and more and more terms in it, they couldn't cope. And certainly when we wanted to put secondary care in, they just couldn't cope with what we needed to do.
Yeah.
And computing has moved on. So actually, and processing power is much cheaper. So actually having a coding scheme where those types of relationships, that this is a type of this, you can actually capture in a different way, actually became, that is the way that you would develop a coding scheme now.
Yeah.
And that's how SNOMED CT was developed. So the codes don't mean anything at all. Those links and relationships, which sometimes need to be changed, they're done by actually storing that this is a type of this.
Yeah, it's kind of, they call it a directed acyclic graph, is that right? Where a DAG, so it's essentially like a tree upside down, so it starts from the root and everything is a something else. So such and such is a thing, and you store the little relationships.
Yes.
In the deep tech world, you'd call that a graph database kind of thing. So Neo4j or something like that would be able to represent that brilliantly.
Yes. Yeah. But that was a big, so from a technical point of view, remembering I'm an IT person, it was all so obvious.
Yeah.
I know that's how you do it now. I've taught network databases, I've taught graph databases, but in a university, it's just, that is the way to do things. But the change from where we were to where we needed to go was substantial, because researchers are using spreadsheets to do some of their analysis. They're using relational databases that they've developed themselves, that all rely on that, you know, that this is a type of this is embedded in that code. And I know that I write a little query that looks for everything that begins with these 2 characters.
And I think in a world that's
that apart.
In a world that's a kind of graph database, essentially like SNOMED, Excel is totally outclassed and cannot cope. And one of the things I guess that possibly they never really thought of when they designed SNOMED is that if there's one thing that can reliably completely garble a code, it's Excel. So if you put SNOMED codes, or NHS numbers for that matter, into an Excel spreadsheet, you are in for a world of pain when you try and get that data out again and it's converted it into a date or a currency or some kind of garble.
And I discovered, even if you type the Excel cell, Excel sometimes thinks it knows more than you do and retypes it back to what it thinks it should be when it yeah.
So there's the message. The message is, if you're using Excel, you're doing it wrong.
Well, I mean,
that's my message.
Yeah. But if that's the only tool set that you've got, there are ways to protect yourself. And but
true enough. It is the most widely used programming language in the world, in that more people can have got some level of competence with setting up Excel to do something programmy, whether it's just summing some cells or whatever, but more people worldwide can use that. And but it just reaches a point where the tabular data and particularly the autocomplete and autocorrection, that's the dangerous bit, actually. If it just left the data as you intended it, you'd probably be in a better place.
But and I remember having a conversation with Nicholas Arterbridge at the time. So as I got sort of deeper into the role, it's okay, you want people to move over to SNOMED and people need to do this analysis, but we've not given them any tools. So how is it going to work? And there was sort of a level of confidence that if the world, and there are a significant number of countries that are using SNOMED, then the tools would get developed. And to be fair, they have. So things like the terminology server, they're not as accessible to the people who use Excel, but tools are getting developed by the market. I think the challenge for us at the time was that we, through the national programme, we're trying to push the move to SNOMED, and those tools didn't exist. And certainly when I kept raising that the tools didn't exist, in healthcare, there'd always been that mindset that the market produced the tools. Connecting for Health was set up as a project. It wasn't set up as a permanent department. It was literally set up with a fixed, and that's how staff were employed. Often people were on secondment, people were on fixed term contracts, because Connecting for Health was always set up as, we just need to put this input in for a set number of time, and then the market will do what the market's always done.
I can understand how that happens, but I always find it quite sad that that's the way. It's a bit short-sighted in my view for, essentially the government agency in charge to sort of completely rely on the market to do everything, because there are certain key things the market will not do and will never do, and that's things like generic tooling, the low-level stuff, which in some ways benefits everybody, but that's kind of the reason they won't do it, because what's the point producing some low-level tooling that only has an audience of, say, a few key terminologists at NHS Digital? No one's going to produce that product because the market's too small.
Yeah, but I mean, in defence, I would say, if you look at other markets, so for example, when I worked at the university, we produced a student record system. We set up a project in-house. We actually created it in-house and employed our own programmers. But the market took over, and we reached a point where we said, actually, we want all these innovations that we can see coming out on the market, and for us to produce it ourselves is just too expensive. If we program everything. So we actually ditched our student record system, and the market had evolved. There was a product in the marketplace. It's now been funded by a significant number of universities, not just ours.
Yeah.
And so we bought a product. And
that's sort of an illustration of where the market does do things. So there was a market for that. There were customers, and so the market did it. But there's never been an understanding, I think, in NHS Digital and England as to when the market will do something and when the market will not. So, I mean, my go-to example on this is digital growth charts was something that could have been done by anyone with a computer since about the mid 90s, and no one did it. And then they waited for the market to do it, so mid 2000s, you know, still no one's done it. 2015 goes past and still no one's done it. And there was a few attempts, but it's such a low-level piece of tooling that there isn't really a massive market. People are not willing to pay a lot of money for an improved widget, if you see what I mean, when they already have one that sort of... That's where the market fails. And sometimes you have to accept that there's a thing that if the market's not going to do it, let's just do it centrally. In my mind, you would do it once, open source it, and then everybody has it, including the market.
Yeah, and this is where you get all those different models across the market, isn't it? Because there have been, I can't remember the name of the company now. So there was a company in healthcare who produced an electronic record system and open sourced it on that basis that if you want something like you've just been describing, and it isn't that difficult to do, and there are enough of our customers who want it, then you just pay that small amount. We'll produce it for you, and we'll do it as an add-on widget. We'll open source it, and we'll just make it available. And there, you know, in other markets that does happen, doesn't it? Where you've got maybe a proprietary system, but they open their API. So, okay, they might not have open sourced their product, but they've opened their APIs so that you can produce add-ons that maybe is not in there, that, you know, they don't feel is stealing their competition or whatever, but it makes their product richer because people are producing things to add on.
Yeah, absolutely. That's the sort of thing that outside in the bigger tech world, that's very common. Lots of infrastructural components are completely open source, even when there is venture capital involved, even when there's a business model behind it, because especially in the big sort of exploding ends of computing at the moment, AI and to a lesser extent blockchain, no one would trust it if it was not open source. So a lot of those platforms are open source.
Yeah.
But yet people will still pay for the service because not everybody wants to self-host it. You know, they don't want to have to do the running it of it on premise or whatever. So they say, I'll pay you for the service, even though it's open source. And that gives us the best of both worlds. It gives us a market, and it means that everybody shares the benefit of that platform. But we're in danger of drifting away from terminology here. I'm going to bring us back with something that I read recently about... it's quite an old paper. I think it's from the late 90s by J.J. Kimino. And it's the desiderata for a controlled medical vocabularies, I think it's called. And this is what you were alluding to with how you do SNOMED. And like SNOMED ticks a lot of the boxes in that desiderata document. Yeah. I only came across it recently. I read it last year because of other work that I'm working on. But I found it very interesting. Sort of SNOMED ticks a lot of those boxes. It does. Like the idea of the numbers, the SNOMED code has no meaning by itself. That's just an identifier. You then give it some meaning, and then you say it is a something. So type 2 diabetes is a diabetes. And you can have these subsumptive kind of inheritance relationships all the way down to the very end where it's a leaf node.
Yeah, and also there's no restrictions on the length of that, how deep you want to go.
Yeah.
So if you take, you know, bringing secondary care on board and saying, actually, we want secondary care, the terminology that they use to be the same as we've used with GPs. So actually, you know, we can exchange data without it, a discharge letter ending up, you know, in your GP surgery and somebody has to sit and put like a hook in the GP record, maybe with a scanned version to the full thing, but at least, you know, you've now got somebody who's been diagnosed and I need them in my GP record with their new diagnosis that came from secondary care.
Yeah.
You know, we can send that electronically so that it can just go into the record because you're all using the same coding scheme. You know, we're actually reducing the workload on GPs or on staff within the GP practice because we're just taking that away.
It would be amazing to be able to sort of get a digital letter from the hospital saying your patient's been to rheumatology clinic and has been diagnosed with, and then, you know, something that I can't even pronounce as a GP, you know, some very, very possibly even a fairly recently discovered new condition that's linked to a particular antibody, and being able to just go and almost sort of checkbox by that and say, yes, we'll have that diagnosis and pull it into our record. And as far as I know, though, we're not there like that, are we?
I don't. So I think one of the things I said to you, Marcus, beforehand is actually I am fully retired now. Mm-hmm. For various personal reasons, I actually have not kept in touch in the way that I thought I would. So, you know, other than visiting my GP practice, kind
of out of the loop.
I'm a bit out of the loop, but just on a, you know how overloaded. So I did a lot of work with the BMA during COVID, and obviously, you know, everything goes over the GP desk.
Yeah.
But as lots of ladies my age, I've actually got osteoporosis. So I'm now on medication, but I have to remind my GP practice that they have to do my yearly medicines review. And it's like, you know, and actually I need a blood test because you should be monitoring my calcium levels, that you know, you put me on this really high dose of calcium, but actually if it's too high, then I'm at risk of a cardiovascular episode.
It's very badly done, isn't it? Those kind of... Now, things like annual reviews are a bit easier to do. So GP systems tend to be not too bad, or they shouldn't be, at least, with annual reviews of things. But in the case of osteoporosis, there's a particular thing. Every 5 years, we're supposed to bring people back and often repeat their DEXA scan to see, particularly in the osteopenic group, have they progressed into osteoporosis and need different treatment. That 5-year recall is completely to the four winds, because there is no system within the GP systems that does 5-year recall accurately. So even these incredibly computable, simple things have not been solved yet, which is a shame, really. We're in 2026 talking about a future where AI is everything, and yet some of the simple stuff that is literally a calendar hasn't been implemented by the systems we're paying, you know, £500 million for over 5 years.
And I'm even having to remind my practice that they haven't done my yearly medicines review, and I'm not sure whether that's because it comes up, and so the medication I take, you can take for 5 years. So, and I think they're relying on if it's not working for me, so you can have stomach issues in relation. I think they're just relying on me that I'll go back and say, I don't want to take this anymore. So they're not, but I haven't had my blood pressure checked or anything like that.
Wow.
But it's like you say, I don't know whether that's because things that to me were so obvious in my CRM just are not being implemented. Having said that, the stuff for the sales reps, I had a limited number of things that I implemented for them. If you take every medical condition, I mean, it just blows my mind that I know we're saying it doesn't call you back after 5 years, but oh my goodness, can you imagine going through every single medical condition and working out all the recalls and everything, and then making a report for it, and then making that accessible to end users?
But it's a tractable, it's at least a tractable problem. And the thing is that this is exactly what I'm talking about. This is the sort of thing that can be done in-house. So if NHS Digital had produced libraries of code that included things like that, those recall frequencies and stuff, then we could have nice guidance turned into computable inputs and given straight to the GP suppliers. And that has got to be the future. You know, nice guidance cannot be a PDF forever. NICE themselves are going to actually at some point going to have to step up to the plate by having in-house technology people who can say, that's a nice guidance now. We need to turn it into a clinical decision support algorithm. And crucially, the SNOMED code selection for the inputs of that are the biggest risk area. That's the one area where it all goes wrong. It's when we decide that these inputs to the clinical decision support are true or false. It's when somebody's got this condition or hasn't got that condition. How do you decide? You do a search for certain codes. Who decides what the code list is? That's where it always goes wrong. That explains the CHADS 2 VASC debacle of 5 years ago or so. That was all about the selection of codes, and it keeps happening because we don't do it centrally properly and just share it with everybody.
So now that my memory's a bit hazy on this, and as I say, I'm out of touch, but NICE have looked at this about 3 times now. So I've had a number of over the years, and a lot of it is exactly as you say, that selection of codes.
Yeah.
And I think I remember sitting down with a group where they were putting the new guidance together, and I was sitting in and saying, actually, we could make this a list of SNOMED codes. And there was always a nervousness that I can never get that list of SNOMED codes right. I can describe it, but I need to leave it to that individual GP and their knowledge of their patients as to which ones this guidelines is applicable to. I can't make it so specific that I can say this patient is in and this patient is out. And
that's right.
That is the so things absolutely from a technical point of view that I say are so obvious. You then put your clinical hat on, and you can always come up with a reason that says, well, is this patient included, and if not, and normally we leave that up to that expert knowledge of the GP who can see, who can see whether they've got any contraindications, whether they're not just diabetic, they've also got something else.
Yeah.
And you can describe that in guidelines, but making it completely computable is really hard.
It is hard. And the selection of codes is where the fuzzy bit comes in, where it has a sensitivity and a specificity and a number needed to treat in a way. But all of that stuff, we solve these problems for other parts. So, drugs have studies to work out, and they're not completely safe, and they have side effects and there are risks. Yeah. But we have done the work to make sure we know the number needed to treat, for example, of an acute therapy in stroke or something like that, because we do research. And it seems like nobody's quite willing to sort of go into that area. And the big bodies that have got the funding, so NICE, NHS England, and various other organisations over the years, they're all circling it, but no one wants to be the one that actually goes in and does it. And so they leave it to much less resourced, either individual clinicians or system suppliers who, for example, implement CHADS 2 VASC, and just by getting a couple of the codes wrong, you can miscode people and you can end up with the wrong score. And, that's a cautionary tale. I'll try and find a good link explaining that story to put in the show notes. But like that's where we do need central guidance. That would actually lower the risk because we could do a better job and make sure that it's absolutely tested. Because it is possible to do, say, some of those simple scoring systems, QRISK 3, CHADS 2 VASC, they can all be done. And if they're done centrally, then at least everybody would be on the same scoring system. And you could do national surveillance then to check that you aren't harming people. And that is the challenge, isn't it? That you do need to put these things in place, and then you absolutely need to keep checking that everything's okay. And coming from a very much a more business commercial world where we absolutely would do that, when Microsoft do a new release of software,
they know it is impossible to get every bug out.
Yeah.
It is just impossible. You do not know how people are using the software. You don't know what combination of applications they've got open. There is an acceptance, but once they're alerted of something, they are super quick at literally fixing the things, and that is the way that they operate.
Yeah.
We seem very risk averse to do that in the clinical world.
It's funny though, because clinical medicine is very, very understanding of risk. It understands that there is no such thing as risk-free medicine. Everything we do has a risk. That is not an excuse for not practicing medicine. Just because something is high risk, if you and the patient can come to an understanding about how big that risk is, and the patient's happy with it, so we have to keep moving forward with medicine, even though it's difficult. And even though there is risk. So
and I also think there's a big culture shift in patients. So as an individual, I am more accepting that I have to understand my condition. It's as much my responsibility to change my lifestyle, to change my diet. And actually, I'm the one who's worked out how to do all that. The GP hasn't told me. And I think as a younger generation comes through, there will be less of this, I only do what the doctor tells me.
Yeah.
So I do think we are moving into an area where it is much more of a shared aspect in terms of relation to your care. I appreciate there are, some areas where absolutely you completely depend, on the clinicians.
Yeah.
But I do think there's a bit more understanding about,
there's a patient activation revolution has been undergoing for the last 20 years, really, related the democratization of the availability of information that's happened by the internet, really. Reading a book called Rebel Health at the moment, which is, I'll put a link in the show notes, that's about this patient activated revolution, and that's only going to be accelerated by access to large language models, which can, at the very least, one of the things that they can do, I think, relatively safely, is that they can process what would be medical jargon and they can re-explain it to a patient in a more accessible form. And even if they just did that, and they're capable of so much more, but even if they just did that, that's really helpful for patients because it further democratizes their access to information, and you can ask questions back and then it can ask you questions, and there can be a kind of, you can spend as long as you want refining what it is that you need to know and what information you need to draw out before you go and see the doctor. And then you come in as a patient who's really informed, and that that won't be for everybody. Some people want to essentially outsource that thought process. Go see the GP, don't think about it. Other people want to be very much a part of it, and I think this allows everybody to get what they want, kind of thing.
Yeah. Right. We've gone off again.
We have, but it's been interesting stuff.
Back this time.
So coming back to let's go on to the end of your career at NHS Digital, and were there any things that drove you mad about SNOMED, and what was the best bits about SNOMED? What was the dream, and were there any things that you felt it fell short of?
So one of the questions that I'm not going to quite answer that, but I will come back to that. So one of the questions I asked when I very first started my job is, I remember sitting in on a workshop where the current trainer at Connecting for Health on SNOMED actually gave a lecture to the nurses on SNOMED about what they believed they needed to know and talk about glazed looks. Mm-hmm. So I've always had the question, what do clinicians need? So if you're not a clinician like you, where you're really interested in, the IT and that side of things, you're passionate about, you're a renal consultant and your whole passion is the renal world and IT is just a facilitator.
Yeah.
What do you need to know? How much do you need to know about SNOMED? And I'm still not convinced we've got that captured, because so I did a e-learning module that is, I double checked before we came on this, and I think I've put the link in the notes. So I did an e-learning module for a clinician who's not really interested in the IT or the patient records. What is the minimum that they ought to know about SNOMED? I know when I worked in Connecting for Health and NHS England and NHS Digital, there was never an agreement, and I was often at odds. Other people felt clinicians should not need to know anything and the systems must be much cleverer. And I said, well, I think you're a bit unrealistic at this moment. Well, certainly you were 10 years ago. But I actually think that an appreciation of you're using a structured language and why we need you to put structured elements in a patient record and things not to do about that is really important. And I still don't think we're getting that in clinical pre-registration training. So I produced a module which actually, having spent 25 years at Huddersfield University, I still have links at Huddersfield Uni. And we actually put one on their e-learning path platform, so that nurses, before they go out on placement, at least they know the structured language. They know it's important that they don't put in a record which we've actually seen in real records, where you put, say, diabetes in the diagnosis and then in your notes you put excluded because I did this test and I know they've not got it.
Yes, absolutely. And people create pro formas like that, often using clinical coding, not knowing that is an absolute no-no, but that kind of free text negation. I used to see a lot of that. There are loads of those in the prison sector. So lots of these pro formas that have been created by somebody without any terminological input. Yeah. And a lot of them will say yes/no to a read code, but all of those read codes go in the record. And then when the patients get released from prison and their records are transferred back to their original GP, it looks like they've been diagnosed with about 40 different things. And that's just because those read codes were entered, but then it said no evidence of.
Yes.
That's that's the absolute no-no of clinical coding. But you're right. The problem is that I think SNOMED, whilst being terminologically near perfect, is clinically almost useless, or at least it's very, very hard. I think the learning curve, it's what you're alluding to, is the learning curve of SNOMED is quite steep for clinicians who just want to do the work and not be involved in the informatics.
Yeah, but so I spent, I guess because fundamentally I'm an educationalist, so so I started, as I said, as a maths teacher in 1977, and I finally came out of that teaching community in 2009. So although my last 5 years at Huddersfield were in management, I'd been a lecturer for a good number of years. So my gut reaction to things often is, well, we're not teaching the right things if it's not. So I thought, I boiled it down to, you don't need to know that there's codes behind it. You don't need, you don't need to know what the read codes were, but you need some fundamental things. And I still don't believe, other than I've done this module for Huddersfield University, which they've got on their platform. If I'd have kept going, what I was hoping to do was, in effect, make that open source and then make it available for lots of other universities, so that at least you've done something that says, when you're filling in a record, there are structured elements of the record which are really important to complete. You can't put free text in it, and you actually have to be fairly careful that you don't then modify or negate what you've done in the text. And I still don't think, what are we, over 15 years, so that was one of the things that when I first got my job that we were trying to do. And I've delivered loads of lectures to, I've been to the Royal College of Surgeons, Royal College of GPs, Royal College of Physicians, and given lots of talks about, you need this basic understanding of SNOMED. And they all go, yes, yes, yes. Right, can we put it in pre-registration training? Oh, pre-registration training is really busy. yeah, but you know how you can drastically get things wrong if you don't understand these fundamentals. So, and also... I've seen, so there are some case studies on the, so if you look for SNOMED, NHS SNOMED case studies, there are some amazing case studies where, we're talking about, why can't I get an alert that it's 5 years since this patient had the DEXA scan? You need to send them for another DEXA scan.
Yeah.
There are some nice case studies of where people are doing some really innovative things in making the care of patients much better by using SNOMED. I think Bart's Health did, when there was the issues with thrombosis, when people had the COVID vaccines and people were being admitted to hospital and these were always getting picked up, they actually put something in that although you were seen in A&E and you might be admitted, it might have been an hour or so later or overnight, but actually we got alert with, we admitted these 5 patients yesterday, and we've now had a look in the depth of their patient record, and actually if you need to go double check these things. And that's the clever stuff that SNOMED enables, that we were hoping, would come out as systems evolved.
It doesn't mean that just because it's not happened yet doesn't mean it's not going to happen. I think those things are absolutely to play for, but we do need, I think, more leadership from the centre. The NHS tech leadership needs to buy into SNOMED CT across the board. I mean, GP has sort of been mostly done, but the rest of the system has kind of lagged behind, and they're without a strong message to say, just like everything should be NHS number identified, all diagnoses should be SNOMED coded. I'm not hearing that from the centre.
No, and so it is quite difficult to do it from the centre. So the centre, there's a standard in place. When I worked, every talk and everything I gave said, you have to do SNOMED. But the NHS is a different beast, isn't it? So when I worked for Herxt and we produced our CRM, because we were being innovative, we weren't the only country that was producing our CRM. Germany produced something similar. America were doing something similar. And when it bubbled up that actually we're now hearing in the centre that these amazing systems are doing all these clever things, they basically got us in a room and they said, right, you've got 5 minutes, demo your system. So literally all the different projects that were being funded all demonstrated their system, and the big boss said, right, okay, you stop developing, that's the one we're going with, right, everything else stop. And that's what happened. We don't have, the NHS is much more of what I class as a federated type. We don't have that command and control, for good reason, in the NHS. So pushing everything to the centre, I personally don't think is the right way to go. I think it would be much better as like little centres of excellence where there's additional funding given to a particular hospital and a particular specialty. But
Yeah,
they,
I mean,
and then
any of those models are potentially doable. I think what I struggle with is that we're buying systems from the market, and these systems don't support SNOMED. So why are we buying them? You know, we have the entire secondary care EPR suite is in most cases not using SNOMED CT, not coding. So why are we buying those things? If it's about the market to do those things.
So, right. So Cerner Millennium does, an Epic supports SNOMED. So I'm not sure. Certainly when I was working, I didn't see that in the same way. I mean, there were some specialty systems that had been having coding in for years, and one of the challenges moving them over to SNOMED. And, you know, if they can send you the data in SNOMED because one of their clinicians has said, okay, we've been doing this way for years, and these are the terms that we use, and they work for us, and these are the SNOMED terms. And when I send you a document, I make sure it's got SNOMED in. I personally don't have a problem with that. You would hope that over time they would see the sense of migrating their solution to SNOMED, so they didn't have to do that mapping. But I remember going to, I think it was Birmingham, to the oncology unit, and they'd got like 20 years of oncology data that was all coded, but in their own local coding scheme.
Mm-hmm.
So, you know, one of the challenges to them was, I understand why you want us to move to SNOMED, but what do I do? You know, at this moment in time, we've got these projects and this, and I can't, you know, it is going to take at least 10, if not a significant number of years, to slowly move in the right direction.
Absolutely. I think that all of these things are going to take time.
Yeah.
So, well, I think that's probably it's a good point to sort of
Yes.
bring it to a close. So is there, in sort of a final few minutes, is there anything that you would like to see happen in the next few years? You know, you've retired now, so it's not for you to solve these problems. What needs to be done, and how do you see that happening?
Yeah, I mean, I always had the idea, if we give data back to clinicians so that they have a better understanding, and data to management, and actually having what Charles Guttridge always called research ready data. So it's, you know, when I worked with the nursing school, if they wanted to do research, they had to get permission to pull paper records, and then the first phase was coding everything. You know, being able to go to a repository where everything is already coded and you can start your research. The type of work that we need to do in understanding healthcare, improving care, etc., I think would just move at a much more rapid pace. And, you know, that light bulb moment in a business, that you give me this system and all of a sudden I can get all this information, which means I can improve how we operate as a service, that almost light bulb moment, that there's this amazing repository, and actually if we invest in some analysts to help us get that data out and improve the service that we offer. So the types of stories I was, you know, when I started my job in 2009, so those types of stories where there's a patient who wasn't given their diabetes medicine, even though when they were admitted, we reported that there were a diabetic and this were the medicine, and they've gone 3 days without being given their medication. IT should not, you know, that should never happen if the IT is being used properly. And these things where we don't realise until 5 years have gone by and something's been going wrong, but we've now, you know, there's a lot of patients that have suffered. Again, that IT surveillance should mean that we're not waiting for that to dawn on a member, you know, that should be alerted much faster. So
Yeah, definitely. I think that
It's to be driven by the care providers. I don't think that gets driven very well centrally. So, but it's trying to make sure the resources in either centres of excellence or something like that that's moving that type of thing forward.
yeah, I think there does have to be a message from the centre that says this is how
Yeah,
to do things. So, I mean, I know I take your points earlier about the centre, but we have a centre. They have all the money.
yeah,
Nothing happens without the pressure that can be applied, the driving force that comes from resources and money. And for them to sit on all the money and not send out strong messages, not give clear leadership about use of coding, education and training around coding, undergraduate education around coding, all of that stuff, it's not going to just magically happen. So
no,
that's what I think, needs to happen. But to pick up on your point about data back to the clinician, that's been proven time and time again to be the real, as you say, light bulb moment for terminology use. It's when you get out of the system the data that you've been putting in, so you can do your own audits, you can look at your own care, you can get feedback, and it helps improve your education, your training, your practice, your business. All of those things can be, so it's like dog fooding your own data, as they say. It comes back to you. That's the point at which people's interest in the data entry side of things markedly improves.
and also that feedback loop improves the quality of the data.
Totally.
So when you've missed a patient, or you've got this patient and you say, why is that patient in my list? Oh, because somebody's put in the free text, but actually that's the opposite to what they've coded it as. So
it helps it to be sort of repeatedly cleansed, and you get gradually you're tending towards better data quality as opposed to tending towards less good data quality.
Well, and sometimes you feel like the data's just been put in because there's a requirement to put it in. Whereas if the data you were getting out was helping you, you would have an invested interest in making, you're not just putting it in to meet a guideline or a requirement somewhere. You're putting it in for a reason, aren't you? And sometimes I feel like the data is put in because we have
for
to
the sake of it.
Yeah.
Absolutely. Well, I think that's been a really good sort of general tour around how you got into terminology and some of the fundamental issues around terminology at the level of the science of terminology, but also like the applied people science of like, how do you get this into use and stuff. It's a really interesting area. And because of that, we are going to do a couple more episodes talking to different people who've got different roles in terminology and trying to explain it as well, because I think there's a lot of background to understand. Where did it come from? What is the point of it? What are the benefits? And so we're hoping to cover all that in the coming months. And I'll put them into a little playlist, so it'll be like a terminology playlist, and this episode will be part of that. So thank you once again, Denise, for joining us. And if you'd like to come back and talk more about terminology, some other aspect of it, then we'd love to have you back.
All right. Thanks very much.